Okay, thank you, John. Good evening, dear colleagues and friends. Wherever you are, good morning, good afternoon. All the time we are saying the same. Assalamu alaikum. Today, really, I'm proud to have an eminent speaker with me, and I'm pleasure also to introduce all of them and to have a new also. We all most of the time we are having cataract in the last, I think, maybe a few months. Sometimes we are having retina. Today we are having little bit changes, and I think it will be an interesting, especially if we are having like an eminent speakers like those they are here with me. And I'm glad to introduce all of them. I am Dr. Muhammad Al-Amri. I'm an anterior segment surgeon and medical retina specialist. I'd like to introduce the co-moderators here and one of the uh, dear friends, and she is one of the MEOM board. She was also helping in also preparing for most of the glaucoma sessions. Dr. Barrel, and she is a professor, Department of Ophthalmology, Government Medical College and Hospital, Chandigarh, India. Also today we are having also Dr. Shibel, and she is MBBS MS, consultant ophthalmic surgeon, Fortis Memorial Research Institute, Gurugram, India. So forgive me if I just say it incorrectly. My dear friend, also Dr. Hayat, he is an pediatric ophthalmologist, strabismus, ocular genetic specialist, and he is in a medical clinic, Parkview Hospital, Dubai, UAE. And lastly, we are going to have Dr. Muhammad Suhaib, and also a dear friend, consultant ophthalmology, glaucoma specialist, director of ophthalmology division, American Hospital, Dubai in UAE. John, if you can go to the agenda, please. So, and we will have Dr. Barrel. She can also join here to moderate the sessions. We will have first, after the permission, we'll start by Dr. Muhammad Suhaib. He will give a talk about trabeculectomy, practical and peers. Dr. Muhammad, the mic with you.
Thank you very much. I'm just going to share my screen. So everyone see my screen?
Yes, it's clear.
So okay? Very clear, great. So we're going to be talking about TRABs and BLEBs and the tips and pros. Now, trabeculectomy, as we all know, has been around for a very long time. I don't have any financial disclosures, but we're going to discuss some techniques that I've learned along my way, along my journey as a senior house officer, a specialist registrar, and a fellow. And basically, trabeculectomy has been around for a very long time. It really has stood the test of time, as they say. It was first described by Dr. Cairns in 1968, and then there's been developments and enhancements since then. There's been the advent of anti-metabolite use and safer surgical techniques, which came along after we started using anti-metabolites, and we started to see that possibly the misuse or using too much concentration or not doing the surgical technique correctly can lead to complications within a trabeculectomy. And historically, trabeculectomy used to have a complication risk of nearly around 20%, but we are now able to quote a lot less than that, near to about 1% with safer surgical techniques. And the main thing is that not as much as when we should be, what we should be doing in the surgery, but actually how we should be managing it afterwards. And as mentioned, the risk used to be very high. There were changes in the surgical techniques. And then after the advent of anti-metabolites, the complications went up again. And then, with these safer surgical systems that have been devised, there's no one right way of doing trabeculectomy. I'm not going to advocate that you should be using this system, but you can take these tips and you can incorporate that within your practice. But essentially, the Moorfield safer surgical system with the use of anti-metabolites has reported a very good success rate with no cases of endophthalmitis, hypotenuse maculopathy, retinal detachment, or blindness. Let me just go forward a bit more. Okay, so This is a slide from the National Trabeculectomy Database from all the way back in 1999, where the risk used to be in the region of about 25%. And with the advent of the Moorfields protocol from Professor Koh, who was my mentor, the risks that he quoted was in the region of nearly 1%. And we're going to go through some of the pearls that are involved in this. So basically, we advocate that there should be a fornix-based incision. And the reason for that is that you don't want to have a line of scarring or a wall of china, so to speak, on the conjunctiva when you are doing for example, a limbal-based incision. So the fornix-based incision is important. It is important to use the correct instrumentation. Here we're using a Moorfields forceps and Westcott scissors to do an ample dissection of the conjunctiva. It is important to spend time doing the dissection and ensuring that the flow that we're going to get is going to be as posteriorly as possible. Again, it is also important not to use as cautery if you can help it. That will entice inflammation and scarring, except for the points where you are going to have issues with, for example, making the scroll flap. Here we are using a little bit of cautery. It is important to try and blanch the conjunctival vessels. You can use phenylephrine, you can use brimonidine to blanch the vessels before you embark on doing the conjunctival dissection. That will help with your the control of the bleeding. Now, usually we do a rectangular flap. It's a 5 millimeter by 2 millimeter flap. It's important to get the thickness of the flap right the first time. If the flap is too thin, you will not get the control. If the flap is too thick, the resistance will be too much. And again, it is important to do a 5 by 2 rather than a 4 by 3 because you don't want the flow to go from the sides. We also do what we call a Lewicki infusion. This is an anterior chamber infusion, and that helps to maintain the anterior chamber, prevent any intraoperative hypotony or hyphema that may occur as a result. Here we're using mitomycin sponges. We use, I'd say around about, depending on the case. Now, if the patient has been using drops for a long time, you feel that their conjunctiva is quite inflamed, then you can use anything up to about 0.3, 0.4 milligrams per mil of mitomycin C, soaked in sponges for about 2 minutes. No more than that, really, because the cells, the conjunctival cells, take up the maximum amount of mitomycin at around about 2 minutes. Here we're using a 101 core punch. It's a small punch, it's smaller than what we usually use to get a more controlled flow. And we do an iridectomy, as you can see here with this. I'm gonna fast forward on the video a little bit more. So here we're using releasable stitches. Now this is something that may feel a bit more cumbersome than the normal stitches that we usually use, but the releasable stitches really gives you complete control of the surgery. You may need to put 3, you may need to put 4. But essentially, people argue, okay, we'll just put a stitch and we can suturalize it later. This is an all or none phenomenon. It's 0, 1, 0 or 1. It's a binary phenomenon. But releasables, you can titrate them as the patient is coming to see you in the clinic, potentially on a weekly basis. It is important to consider how what the patient demographic is or what the logistics are. You need to consider whether they are able to see you on a weekly or a 2 weekly basis. It's important. So here we try and make sure that it is completely tight. And with the Lewicki infusion around 10 centimeters above or 10, 15 centimeters above the patient's head, you are able to get a pressure on the table roughly around about 20 millimeters of mercury. And here we're going to be using stitches on the conjunctiva, which again are sliding stitches. You can lock them, and this will help to tighten the conjunctiva at the point of the limbus. We do a mattress stitch in the middle and two knots on the side. So here you get a almost like a complete fortress. Here we're using a little bit of extra conjunctiva just to make sure that we're not going to get any melting at the limbus. And see, we've taken out the Lewickian fusion. It's a very controlled surgery, very little bleeding, no hypotony, intraoperative hypotony, and you close. So the Lewickian fusion actually adds. It actually takes you away from the issues of hypotony that we get. Now, we've discussed all this during the video, so I don't really need to go through all of this, but this is basically, all the things that I've just told you about the safer surgical system and the use of releasable sutures. Now, bleb management, what do we want to achieve? What do we want to achieve from the surgery? We want a good target IOP. We want a low-lying diffuse bleb, a posterior draining bleb, a bleb limited to the subtarsal region. And the success is achieved pre-operatively, per-operatively, as we have seen, and also post-operative measures. You need to consider the surgical site. You need to consider the pre-op erythema. Is it good to withdraw some of the topical medications? Should you be using steroids? Should you be using acetazolamide to get the pressure down, calm down the conjunctival inflammation, and then do the surgery? Consider previous scarring. Consider, as we have mentioned, the age, ethnicity, the target IOP, and consider the levels of antimetabolite you will use as a result of these findings. So a fornix space dissection, a large dissection, a rectangular flap, the antimetabolite use, the use of releasable sutures, and if there is not a bleb, so for example, you see on the first day there's no bleb, you can burp the scrotal flap. Now, this is the way you need to do the releasable sutures. You're very welcome to email me, and I will send you the slides, and the video is on my YouTube channel. So you'll be able to see how this is done. The healing cycle is important. You have a window of about 4 weeks, but you must consider the latent phase, which is up to the 1 week, and then the inflammatory phase, which is 5 to 7 days after, and then the proliferative phase of the healing process. So as the time goes by, the releasables will do less and less. So you have really a 2 to 3 week window in order to get them down to the target pressure that they need to be at, essentially. And that should entail the use of the appropriate amount of steroids as post-op drops, slow flap suture manipulation, antimetabolite injections, 5-FU, 50 milligrams per mil as you need, and the needling. Please do not be scared of needling, even on the first week. If you see vascularity and you see encapsulation, then you must proceed with needling. This is the way that blebs are graded: a flat one, a low-lying one, a medium bleb, and a high bleb. Now, it's very important to incorporate all of these things because it allows you to understand the fluid dynamics that are happening within that bleb. You don't want a bleb that has a wall around it because it will eventually become cystic. You don't want a bleb which is draining, for example, to the lateral parts of the eye, because essentially the conjunctiva will get chemotic and the patient may experience pain. So we use steroids, antibiotic, and atropine in the first week. Atropine I usually remove after about a couple of days because I just want the eye to be more relaxed, stabilize the blood aqueous barrier, and then I usually remove it. Antibiotics we continue for until the stitches are there for at least about a month. The steroids, you can go up and down with it depending on what sort of pressure you have, what sort of bleb appearance you have. And again, you can do the needling within the clinic. You can do that on the slit lamp. You can do a type 1 needling. Of course, the type 2 needling, I usually recommend that to be done in the theater. But skull flap manipulation is important. You need to consider whether you do need to do a type 2 needling where you're going underneath the flap. Now, here this is a picture of how people actually burp the bleb. So you can see that you must try and press above the lid, just at the edge of your horizontal margin of your skull flap. That is the place where you should be pressing, not on the cornea, not behind the horizontal line of the skull flap, and not at the bottom. This is again to do with the physics, and you can see that demonstrated on this balloon. And suture manipulation is very, very easy. You can take the stitches out, you can manipulate it with a core paddle forceps or a blunt forceps, and you can use antimetabolite injections when you have grade 2 or 3 vascularity. So corkscrew vessels, pressure being high, or you feel that there is scarring developing within the walls of the bleb. It's important to use, so how do we do that? How do we do the needling process? Now, again, this is a very meticulous process. It's not just simple as just sticking a needle in and moving it around. You need to use an appropriate lignocaine 1% anesthetic, a phenylephrine to blanch the vessels, a long needle track, a slow injection of 5-FU 50 milligrams per mil, about 0.3 mils, 0.1 mils in each quadrant. I'll just show you a video. This will actually allow you to understand how we do that. And so here you can see that the bleb is, sorry about the quality of the video. Apologies for that. But you can see that there's a lot of vascularity. There's no real bleb. And we're using a Moorfields forceps. We're using a 25 gauge needle, or an insulin syringe with a needle on it, with some microvisc. So essentially, you can inject the microvisc on top, and then you can inject the 5-FU around it. And you will be able to see. Now, we're not using sweeping motions. We're using to and fro movements of the needle. This is what is going to help to break up the scar tissue. The sweeping motions will actually cause bleeding to occur. And you really don't want bleeding as much as you possibly can, especially if you're going to do a type 2 needling. So you can see that we are trying to get some sort of flow. Inevitably bleeding, can occur. There's really nothing that you can do about it if it does. But essentially, when you are doing a type 2 needling, that you should try and enter the scleral flap first, break up the scar tissue around the flap, make sure that the flap is free flowing, and then do the conjunctival needling of the scar tissue. So here I will show you some pictures, just in the interest of time. So these are limbo
Dr. Muhammad, can you please, if you don't mind, to conclude?
Yeah.
Already
Okay.
are over the time.
So this is 1 month post phaco. This is a bleb after phaco trab with an IOP of 9. You can see the corkscrew vessels. We did a 5-FU injection here, and essentially we found. I don't know if this is it. Okay. So I'll skip here. I'll skip this slide. But basically, this is a patient that we did a left trabeculectomy on. You can see the bleb. It's diffuse, it's low lying, and there's very little vascularity. This patient needed about 3 5-FU injections after the trabeculectomy. But I guess you understand the gist of it. These are cases that I had these are like little puzzles. So this is, essentially it's a puzzle that you need to solve. So essentially trabeculectomy is a gold standard. It's still a gold standard for a majority of our advanced and severe glaucoma patients. And you can take away some of the techniques of the safer surgical system, which will allow to make your surgery safer and more predictable, and for you to have more control. And please don't be shy of needling the bleb, injecting 5-FU whenever you need to do so. And I thank you very much.
Thank you very much, Muhammad, for an excellent presentation. Dr. Barol, if you want just to ask any questions, we have 3 minutes for discussions, or 2 minutes now.
Yes. Dr. Mohammed, another tip which I have tried with needling is that you inject a little bit of xylocaine or the anesthetic agent under the bleb that delineates the fibrotic areas, and the conjunctiva, which is free from fibrosis, that sort of stands up. So it makes it easy for you to recognize where to sweep in. And I agree with you that sweeping motions, they lead to more bleeding. So that's a very valid suggestion here. But then other than micro-whisk, xylocaine can also come in handy.
Great. Yeah, it's an excellent, that's an excellent suggestion actually. And definitely we do inject, and this is what I wanted to make clear as well, that we do inject that at the beginning. Is, when you're doing the patient under local anesthesia, of course you do inject the xylocaine at that point. And you're absolutely right. I mean, the scar tissue becomes quite visible at that point as well. But of course, for example, when you are doing a type 2 needling, it's important for you to be able to see the edge of the flap. So I guess I gather that you inject the xylocaine posteriorly, and then you sweep it into the area of the bleb, right?
Right. Yeah. And do you do any sort of imaging prior to taking up the patient for needling? Do you see the patient or using a UBM or an anterior segment OCT to see if the scleral root of the bleb is patent or not? Or
yeah, I mean, that's very important. So again, it's to do with the planning, like you're saying. It's important for you to know that you have an ostium, so you do a gonioscopy, so that you're able to see exactly whether the ostium is open or not, it's not becoming plugged. And then of course, an OCT will of course be very, very helpful for delineating what you've just said. Yeah. And then of course the conjunctiva, like you said, with the xylocaine, you're able to detect the scarring and everything. So all in all, you covered all the bases from the anterior chamber all the way to the intraconjunctival space.
Yeah, you truly mentioned that the job of glaucoma surgeon starts after you have done your trabeculectomy. You really have to nurture the bleb with all the tips and tricks in your kitty. So there are no questions. Yeah, there is
one question
here.
Yeah.
So is there any role for anti-VEGF in trabeculectomy? Would you like to share your experience?
Yeah, to be honest, when I was training, we did use Avastin in the blebs, the bezivizumab, and that does help a lot with the vascularity. So, for example, if you do have a patient that has a vascularity of 3+, then that is something that you can use. And again, it's a trade-off between how much 5-FU can you really use before making the bleb avascular. And, and then of course, I think using both is an excellent idea. There's definitely a place for using anti-VEGF in blebs. I agree.
Yeah, for that matter, VEGF is involved in every wound healing in the body. It's not just the bleb, anywhere where there is an injury and it is healing. So VEGF is important there, and anti-VEGF would definitely modulate that healing process. Dr. Bharti, I would like to ask you, what's your take on the post-operative care for blebs? Dr. Mohammed has made very valid points, and what's your experience about this?
We try and steer away from anti-VEGF both during and after trabeculectomy, because MMC and 5-FU have proven to be far more efficacious. And that's not just my experience, it's all kinds of long-standing, long-drawn, randomized controlled trials that have proven that both of these two drugs are more important immune modulators than anti-VEGF can be, not to bring in the cost factor also. So we are needling with 5-FU and MMC.
neovascular glaucomas or uveitis?
Of course. So then we would do it, also use the anti-VEGF before we do the surgery for neovascular glaucomas. And since in my hands, I do very little trabeculectomy for any secondary glaucomas, I know you do more trabeculectomies than I can ever imagine. So that is when anti-VEGFs do come in a big way. But I thought we were talking wound modulation and not the surgery per se.
Yeah, so a lot of people have tried using Ologen, which has been soaked with Avastin, as Dr. Mohammed mentioned. But yeah, I mean, it was just tried by several people when Avastin had just come into the market, but nothing concrete came out of it. And so, you're just adding extra cost to the surgery. And so it, just fell out.
All of us have gone back to MMC as the modulator of choice, not 5FU also so much until you're looking at the post-operative period.
Yeah, so everything we have tried, but then we have all gone back to the roots for taking care of every small bit of conjunctival fibrosis that's happening, recognizing it in time, and as Dr. Mohammed said, doing the needling at the right times to get the right outcome. Dr. Hayat, are you there?
Dr. Hayat, you are with us?
Yes, I'm there.
Is there any comment from your side?
No, I think this is an interesting discussion. And my understanding is there are always more than one ways of dealing with it. And I don't have any, personally, I've never used anti-VEGF for these cases. So, yeah.
Okay, Dr. Baral, I will ask you now the questions, Dr. Baral. If you want to conclude from Dr. Muhammad, what are the most important points that we need to highlight on in doing trabeculectomy or preparing for trabeculectomy and post-trabeculectomy?
So preparing for trabeculectomy, I think, is one of the most essential things. If the conjunctiva is inflamed pre-surgery, the chances of the bleb failing or fibrosing after the surgery are quite high. So you need to sort of settle the inflammation that is there preoperatively. Some people prefer to stop the topical medications and they switch on to oral steroids for a while covering up with an oral acetazolamide for the time being as regards the pressure. Having said that, doing a meticulous surgery, keeping the anterior chamber formed throughout the surgery, and doing a watertight closure of the trabeculectomy is utmost important. Having a low intraocular pressure is way worse than having a high pressure in the immediate post-operative period. And in the immediate post-operative period, recognizing the early signs of fibrosis in the form of corkscrewing of blood vessels or wrinkling of the blood vessel contour, that is something which is of utmost importance. You can take care of it by giving 5-fluorouracil or by increasing the steroids, but that has to be taken care of. A lot of times this can be dealt with steroids and even encapsulated blebs. If you take care of the cytokine storm in that critical period of about 3 to 4 weeks post-surgery, a lot of blebs can be salvaged. But if they are not salvageable, then needling, of course, can be done. If you're an expert, a slit lamp needling usually works. Otherwise, it's better to take the patient to OR rather than being too experimental on the slit lamps. So with each person's experience and as their hands get steady on slit lamp, the needling can definitely help. So
thank you very much. I think there is only one question in my mind. If there is, and you said some cases there is a repeat trabeculectomy. I mean, what is the things that you, or the indication to repeat, and how do you manage to deal where you have to change the place and so on? If Dr. Muhammad or Dr. Shibel, if can comment.
To be honest, in my training, I was always told that if one has failed, then just move on to the next step. And, I've seen patients that have had 3 trabeculectomies, 4 trabeculectomies, and it's just a mess.
Yeah.
So to be honest, if one has failed and it has done its test of time, then it's better to proceed to the next step, because ultimately, you're not going to get the same effect. The conjunctiva is already primed; it's already been opened, and so that's always going to have a much less of a efficacious result. as a second trabeculectomy. So I always move on to tubes if a trabeculectomy has failed.
I agree. And if you haven't been trained in tubes, please refer to someone who has. And that's, I think, something
that's the other point.
Emphasizing on every time I speak, is that if you can't do it, there is someone in your city or wherever you are who can. And it's good to not try out a second trabeculectomy if you have access to tube. Otherwise, you have to look at a second site and just make sure that your anti-metabolite use is smarter than it was the last time. So if you used a 0.1 or a 0.2, step it up, maybe use it for a couple of minutes instead of the 1 minute that you used it for. But I mean, I am not a believer of second trabs. I know Parul doesn't either. So
No second trabs.
No second trabs. It's just, you're flailing a dead horse, so it doesn't get you much. So move on, find somebody. If you don't do tubes, if you do tubes, perfect. So referring is so important in glaucoma surgery to people who know something that you don't. It should never be an ego hassle that I am a glaucoma surgeon, why would I refer to somebody else? You won't, because they have trained differently from you. So I'm the happiest to send my trabs to Parul.
Okay, thank you very much for all of you. I think we need to move to the second talks, and is now the time for Dr. Hayat Khan, my dear friend, and he is going to talk about goniotomy pearls.
Thank you so much, Dr. Amri. I would like to just share my slides. Just 1 minute. Let me just. So, of course, this is an interesting topic. And the important thing is, especially being a pediatric ophthalmologist, I definitely would like to stress out the point that if you can do one surgery and learn one surgery to deal most of these cases, the way to go about is, of course, to learn how to do a goniotomy. So is my slide there? My slides are there?
Yes.
Okay. Yep. So here we go. So I don't have any financial disclosures. Now I'm just restricting my talk. This is a vast field, but I would like to just restrict myself to congenital glaucoma cases. So primary congenital glaucoma, as we all know, can be one of the entities, but we can have other entities where glaucoma can be associated with syndromes. And of course, there's a lot more that we have in all secondary glaucomas associated to the adulthood. So we have to first of all know what we're treating. Of course, we all know when it is a primary congenital glaucoma, it has a typical presentation, photophobia. So it's important what we diagnose. The most important thing is to make a correct diagnosis, because there are so many entities. And I have seen sometimes people going into cases like megalocornea and being operated, and later on, it turned out to be genetically a completely different condition. And of course, the first line of treatment would be an angle surgery. And when I say angle surgery, well, if the cornea is clear, then goniotomy is the way to go. If it is not clear, then our trabeculotomy is the one that would be the second choice. Once any of these surgeries fail, we go in further and we go into other treatment modalities. So it's important we know the angle. Most important thing is for any surgeon to have a successful surgery, we not only need to know the structure, we need to know the pathophysiology, how the structure is oriented, where the iris is inserted, its insertion is high, and all the compaction of the trabecular meshwork pillars, which has formed like a pseudomembrane, Barkhan's membrane, and which has caused decreased outflow. And our main objective is to open up this angle. So in pediatric patients, of course, we have to have a cornea, which has to be clear, and only then we can go about. So here we have a case, a 36-weeker, which was earlier examined elsewhere with a large cornea, and he was referred us to pediatric ophthalmology unit to rule out glaucoma. Sometimes these cases come up late, especially the ones who develop a hazy cornea are difficult, because once the haziness has set up, it's difficult to treat. Well, children as such, there's a lack of cooperation and the anatomical differences are challenging. So in a clinic, whenever I actually have some problems in my multimedia. I have a couple of videos which are not loading. I apologize for that. But definitely I like to illustrate that HAPS try as well as cornea haziness can be a problem whenever we are doing cases where we have to do a goniotomy, and it's preferable to do a trabeculectomy or a trabeculectomy with trabeculotomy. So in the clinic itself, it's important that we do a thorough examination. We measure, possibly if we can measure the corneal diameter. The way I choose to do is I usually take the ruler, just put it just next to the corneas and try to take a picture and then measure the size of the corneal diameter on the pictures rather than measuring otherwise, because kids in the clinic, they are fighting, they are not happy. And definitely a better examination can be then later done under general anesthesia. So now going on to the goniotomies, how we plan it. The most important thing whenever we are planning is we have to have a good coordination with the anesthetist, and we have to ask him that if he can just let us know the moment the patient is in and is deep enough to have examination. And the first thing I would like to measure is the intraocular pressure. Then indispensable instrument is a portable slit lamp where I can actually see and choose the surgery, whether there is haziness, where there's no haziness. And I can also augment a copy lens or a Schwann-Jacobs lens to look into the angle with the slit lamp. And that can actually guide me whether or not I would be able to do the surgery well. Of course, the measuring the horizontal diameter is also a prudent way, and taking the axial length to see not only the patient making a judgment call, whether it is a glaucoma case, but also to follow up and see the progression of the disease. It's important. It's also prudent to do a fundus examination and have a picture of the optic nerve head. Now, as we planning, always remember that there are no two-stage situation, that one stage you want to go for examination, the second stage you would like to do the surgery, preferably to just go ahead and straight away book the patient for either a goniotomy or trabeculotomy. That is the way to go. So using an irrigation goniotomy knife or an MBI blade, and some of my colleagues, they even use a 25 gauge needle with a cohesive viscoelastic cannula. And once they go in, they can actually, some of them can use the viscoelastic to make the anterior chamber deep. But to start it, it's most important that we tilt the microscope at a particular angle. And once we have the microscope tilted, we have to tilt the head on the opposite side away from us. If we can have about 30 degrees of tilt, that is an excellent position. I always choose preferably a temporal approach for which I can have the nasal and inferior arc to cover for my goniotomy. We can fixate the globe with a stay suture, or we can even use a locking Moody forceps. And once we are holding it, once we know that we are comfortable, then we can actually put the eye in the position which is away from us. On my personal choice, I prefer, of course, temporal incision. At the corneal limbus, I try to make a longer incision, and I would like to incise at least 120 degree of arc of the trabecular meshwork on the nasal or inferior nasal side of the patient, of the eye that I'm operating. I prefer use an MBR blade. The reason why I prefer is that I can go either side very easily without rotating the instrument, which is not the case with some other instruments. So MVR blade, it helps in not only getting in and making a good incision, but also I prefer, and of course I do use cohesive viscoelastics to make the anterior chamber deep. Sometimes if I see the pupil, if it is large in size, I would rather before starting the surgery, I would rather inject in some molecule to have a smaller pupil, just in case, to protect the lens, which is just adjacent. So once I have entered, and I prefer to focus the nasal limbal vessels, which is on the other side, because I know once I have that in focus, I can go deep and I can actually focus on the trabecular meshwork, which is at the same approximate distance. I apply dispersive viscoelastics on the cornea. Cohesive, I prefer inside the chamber, and I use the disposable goniotomy lens. Even a Sean Jacob lens can be used to focus the trabecular meshwork. This is something which is different surgeons have used different. I prefer to hold the lens rather than holding the eye, but some surgeons, they prefer the assistant to hold the lens and have a good coupling, and they prefer to hold the eye in the position where they can actually have a good visualization of the trabecular meshwork. Once you have a good view, then of course a good magnification can be achieved from the microscope. And then once you start opening the trabecular meshwork, you will see it will spread out by the direct incision. And you may see sometimes some bleeding, and that can be controlled by injecting some viscoelastic while you do the procedure. And of course, if you're doing it right, usually the procedure takes between 2 to 3 minutes, maximum 5 minutes. And the best part about this surgery is that once you've completed, you've sutured it with a 10-0 nylon, the patient has a good amount of conjunctiva which you haven't touched, and it can always be used for a trabeculectomy, or for that matter, a drainage device which may be needed later on. So the same patient, before and after, you see that once we do the surgery, there is a reversal of cupping, which is not so dramatic in this case, but in some cases, there is a very dramatic improvement. So in conclusion, I would like to say that this may be one of the best surgeries we can perform for our children where the corneas are clear. It can also be used as a surgery after doing a trabeculectomy or a trabeculotomy, once the cornea is clear. And it is something which I use so often, and I prefer that this is supposed to be the way to go in case. And these are the pearls that I would like to convey to my colleagues. Thank you.
Thank you very much. Excellent presentation, Hayat. I was anticipating to see how to do it actually in a video. But anyway, Dr. Barul, if you have a comment and questions to Dr. Hayat.
Well, we definitely missed your video. Dr. Hayat is a wonderful, wonderful pediatric surgeon. I have one question. Do you have any tricks or tips for doing evaluating using a Swan Jacob lens with the handheld slit lamp? Do you tilt the slit lamp while you're viewing it, or do you angulate yourself when you're standing and viewing the lens to make it easy?
You're talking about the slit lamp? Tilting of the slit
no, I'm
lamp?
talking about on table.
Well, as I said, that I always, that's another thing, that before you plan the surgery, you need to know that your microscope should have a possibility to tilt it, because that gives you an excellent view. Some microscopes do not have that capacity, and that can be sometimes incapacitating. But another way is if you tilt the head the other side, and if you are sitting on the temporal side, you will be easily be able to get a good view. And the most important thing is a good coupling, which I feel is giving you a good view. Sometimes what happens, you have to just press it a little extra, then you will be able to view the angle much better. But my understanding is the most important is the tilting, which makes the surgery so easy. The tilting of the microscope is very important.
So when you were doing evaluation under anesthesia for these kids, and you said that you use a handheld slit lamp. Now, I was just asking about a tip to make it easier.
So that is it. So we would like to, of course, hold the lens on one side, and with one hand, with the other hand, we can actually use the portable slit lamp, making a tilted angle so that we can go straight onto the trabecular meshwork. And it is so easy to visualize. And once you have visualized, you can even change from 10x to 16x. And that would give you a very good view. And most important is that that particular trick helps you later on when to decide whether this case is good for the surgery. Because I've seen some cases you may think that you have a reasonable good cornea, but when I started the surgery, I realized, well, the cornea was not clear and I was struggling at that point of time. So those cases can be easily taken as a trabeculotomy rather than this procedure.
That's a good suggestion. And I agree with you that holding the lens yourself actually makes a huge difference, because usually the assistant hands are not steady. And right at the time when you're doing the most important step, you can have the release of the coupling medium from the cornea, and you can just lose your focus. So holding the lens rather than holding the eye by the surgeon is a much more practical way to do the surgery. Any other questions from any of?
Yeah, there is, I think, one question. Can you just, Hayat, please stop sharing just to have a more, yeah.
I'm sorry.
Yeah, sorry, Hayat. Is there any question, Dr. Muhammad, or comment from your side to or asking Hayat?
There is a question from Dr. Fariha.
Yeah, I will keep to the end that one. I was to see that.
Okay. I'd say you're very blessed to have an assistant to hold your lens.
Is there any way, I mean, we can have a microscope that connect the lens, like when we are doing, for example, vitrectomy, it will be, I think, a good thing that you are using the...
Actually, the thing is that with glaucoma surgery, this is the other point, people talk about, for example, MIGS, that, it can be done by anyone, but actually that's not true, because, visualizing the angle, it's not something that it's a learned response. So it is something that you learn and you perfect over time, looking at the angle. And because we look at angles on a daily basis, every angle is different, and you need to know exactly where you are placing your blade or for example a device. And the thing is that it's important, that's why in MIGS, MIGS is easier for glaucoma surgeons, because we do these type of procedures, the goniotomy procedure, and not just tilting the microscope, but also tilting the patient's head. So if you tilt the patient's head, you won't need to tilt the microscope as much, and your positioning will be a little bit more controlled. And using a direct gonioscopic lens will be helpful as well. So essentially, it's all about your technique, how big your arm span is, and how you normally sit, your own ergonomics, which helps to stabilize and control your procedure. It's important to be comfortable in doing these procedures, and I guess doing more and more of these will of course improve your technique.
Dr. Shibel, if you have any question or comment.
I'm in awe of people who do goniotomies. I don't do goniotomies as a rule. I am a trab or an AGB person straight out for my pediatric glaucoma. So I'm in awe of people who can do goniotomies. But that said, it's very important to learn gonioscopies if you are looking at any point in time to becoming a glaucoma surgeon who does work on the angle, especially with MIGS. Like Mohammed said, it's extremely important to start using to start learning the anatomy of the angle, and especially using a direct gonioscope. It just turns everything on its head. So yeah, I'm not a goniotomy surgeon, so I'm going to stay away from this one.
Yes, Dr. Barrel.
For people who are trying to learn goniotomy, I mean, the way I have started sort of doing goniotomy on my patients is first getting to use the Swan-Jacob lens, trying it after a phacosurgery on an adult. And that's the time when the angles are most clear. So once your hands are steady at visualizing and mobilizing the microscope in an adult eye who has just undergone a cataract surgery, you can safely switch to children. So that's a good way to practice. Just at the end of the surgery, after a phacoemulsification, just put in a Swan Jacob lens, tilt your microscope, have a view at the angles, and I guess that really helps you to switch to pediatric cases. Dr. Hath, what do you have to say about this?
Yeah, there is definitely a small learning curve for sure, but the numbers are so small when you talk about pediatric cases that you don't really do it on an everyday basis. That's unfortunate because anyone, and especially in UAE, we don't do it so often. Let me be honest. So what happens is that finally it's the cumulative number and how well you can actually plan your surgery, how much time you, like Dr. Muhammad Suhaib said, the same thing I'm repeating. I'm actually always trying both the things to be there. One, the tilting of the head about almost 20 to 30-degree, and at the same time tilting of the microscope. So I augment so that I am comfortable at that time. That comfort only comes once you keep on learning by hit and trial. Well, I did this and I was not comfortable at this particular angle. I feel positioning of my MVR was not comfortable. But one thing I've learned that once you are comfortable in the position where you are, the surgery is a piece of cake. It's one of the, I would say, between, I do practically all the procedures when it comes to pediatric glaucoma. I do shunts, I do tubes, everything I'm doing except I have, in my own humble experience, I've realized goniotomies have been really rewarding. One procedure and then the patient doesn't come back. And that has been really rewarding in some cases. Maybe if my colleagues would like to share their views. Also, I would like to know what are your views? What do you think instead of MBR? There are some new forms of devices which are now used. Would you use in a pediatric case? I have never had a chance to use them.
Unfortunately, in India, children are brought in so late that the cornea is so hazy that we have no other option but to do combined trab with trab, as Dr. Shibal mentioned. And in my experience also, I've just started doing goniotomies when people have just started bringing in the kids earlier. But essentially, most of our glaucoma pediatric surgeries are combined trabs with trabs.
Anybody used co-hook dual lens, dual blade, sorry, co-hook dual blade, the one which is having
yeah, the KTB?
Yeah.
No, I haven't had access.
It's yet to come
Muhammad,
to
I was
India.
wondering maybe Muhammad have used.
No.
No?
Past his
What do
time.
you prefer? What do you prefer using? You use a 2060, you use a MVR. What is your
Yeah, I use an MVR. I use an MVR because you can even angulate it, and it's because it's got it's sharp and it has a very fine you can engage it very easily, and I found that to be very good in my hands. And again, it's with all surgical techniques, it's whatever is comfortable in your hand, whatever is comfortable in your hand and is accessible to the angle at the point of entry. That's what that person or surgeon should be using.
perfect?
We can come now to the last. There is two questions, I think, from colleagues here. They are asking the question. One of them is, in your practice, how many times are you able to go for your goniotomy, and what percentage cornea with cloudy cornea? Hayat, or any other one?
Well, as I said, that most of the cases we do not have goniotomies being done, with the reason simple as that we usually get hazy corneas. I would say maybe sometimes we are underdiagnosing those cases, which could have been diagnosed, but the numbers are small. But in terms of percentage, I would say not more than 20-25% I get to do goniotomies. Mostly I do trabeculectomy with trabeculotomies. That has been what I have been doing. It has done well. What has done well with me, not necessarily is everybody's this thing. So I'm very happy with my results, in spite of the fact that the trabeculotomy part is sometimes, the deep sclerectomy has come up in a big way and has been a good alternative. I don't know if anybody is doing that, but I see that is quite rewarding because, it's another challenge to get hold of the proper anatomical landmarks and have that surgery successful.
I'm happy doing deep sclerectomies in adults, but in children, I'm very worried of experimenting. It's also because my practice is a smaller practice, and like Parul said, we hardly get clear corneas. So if I were to get the occasional clear cornea, I don't know if I'm ready to experiment just yet.
There again, actually, the same thing is we sometimes start, and if we are not able to complete it, we can always change it and redo it.
I saw one of my professors actually abrade the cornea and do a goniotomy. To my mind, it just was a risk I wasn't ready to take.
Yeah.
Okay, I think the last question is goniotomy or GATT is preferable for congenital glaucoma. Any comments from anyone of the panel?
Anyone?
Well, I think GATT in children, once you open up the trabecular meshwork entirely, you run the risk of fibrosis of the excised trabecular meshwork, and the outcomes have been highly unpredictable in people who have tried it. So, although I have no experience with whatever literature I have read, I don't think that it has been advocated by people who really do pediatric.
I have very limited experience with it, and it isn't something I would want to do. The problem with children is that they have a very long time to live. Remember, life expectancy for a child is like 200 times that to an adult. So you have to be very, very careful with experimentation with children. And even though I was trained in that, I don't use it for my children at all. But then I don't do goniotomy either. I stick to conventional trab-on-trabs for as long as I can.
Well, gonioscopy assisted, I don't know, transluminar trabeculotomy, I have no idea in pediatric and any of my colleagues have been doing, but it would be something really interesting to know if it can be tried in pediatrics.
Oscar's done a lot, Parul. Oscar Alves from Mexico has a huge case series of GATT in children. And he's very enthusiastic, and that's what he does mostly, apart from using tubes. But I'm very wary of the fibrotic response, like Parul said. It's like trabectome. In adults, it has failed. So in children, the scarring is going to be absolutely much more.
Thank you.
I think we have to move to the next presentation, and we are honored also to have Dr. Shibel today with us, and she is going to present about contact lens sensor tonometry.
Am I going before Parul? I thought the program had her before me. The happiest to do it. It's way past our bedtime, so just give me a minute, please. Thank you so much for having me here. It's almost like family now. We've been chatting for almost an hour, and one big news before we start talking about the contact lens sensor. My son just came in and he's like, you know what? Cristiano Ronaldo is now with Manchester United again. So he's left PSG. So any football fans out there, if you've been listening to the meeting, you missed the most important news of the season. Ronaldo is back with Man U. It's a seriously well-negotiated contract. That's the kind of money we should be making, especially Hayat should be making, given that he does his goniotomy so well. We're going to talk about eye pressure now, which is what we all are trying to control, regardless of what surgical modalities we use, regardless of what medicines we're using for our patients. Because regardless of what we do, starting from the beginning, which is measuring what we can influence, is also important. And in all our busy practices, we forget that the intraocular pressure is such a dynamic variable, and it is so individual. And the fact that the off-hour peaks are the one that probably influence our outcomes more than anything else. At night, there is definitely a reduction in aqueous humor inflow. The redistribution of the body fluid in the supine position means more vascular congestion in the choroid and a rise in episcleral venous pressure. The decrease in the sympathetic nervous activity decreases both the systolic and diastolic blood pressures. So what happens at night essentially when you and I are not meeting our patients is that the eye pressure increases and the ocular perfusion decreases. And to measure that nighttime change is so critical in those patients who continue to progress when, despite the fact that you have good IOP control during your office hours. So I don't know how many of you have it, but half my patient population is absolutely well controlled and they come to me and they're yet progressing. One, of course, is white collar adherence to medication. So when I go to my dentist, I brush my teeth. So when my patients come to me, they've used their eye drops and they forget otherwise. And the other, of course, is what happens at night. So for almost 70% of our open angle patients, their highest IOP is seen outside of office hours. And mean IOP fluctuation has always been proven to be higher if we see them at night than if we see them only during the day. And in those patients where we actually plot a diagonal variation curve, almost 60% those will actually undergo some kind of a treatment change. And 20% of NTG is not really NTG because their eye pressures are higher at night than the demarcated 21. And your angle closure, and this is something that Parul and I worked on together from 2 different cities in India, the degree of field loss and degree of pass are associated with fluctuations in angle closure eyes as well, which means that angle closure eyes do not behave any differently from open angle eyes when it comes to the diagonal variation of eye pressure. However, the logistics, of course, is you need to hospitalize. Parul can, she's in a government hospital, she's got residents. I have a private clinic. Very difficult for me to stay up through the night doing a diagonal variation. And of course, the agreement between denominators is a problem. So you must have the same denominator for sitting and supine patients. You can try a tonopen or a pneumotonometer or Perkins, but those aren't standardized again. Inter-observer agreement, unless you're ready to stay up through the night, you might have different observers, and that's something that you need to keep into account. What does work sometimes is patient self-tonometry. I'm the happiest to pass on my eye care tonometer to my patients and see what they do at night. But remember, when they wake up, when they sit up, the sleep-wake acrophase means that you're not going to get a true high peak IOP. And if you use a sleep laboratory, I thankfully and very gratefully have access to one, but the cost is prohibitive. And half the patients turn around and say that we couldn't sleep properly at night because we were in alien surrounding. So these are all logistics that mean that the contact lens sensor is actually something that can give us a tremendous wealth of data about what is happening to the patient. So the contact lens actually has a micro antenna and a telemetry chip and a strain gauge. So the strain gauge measures the pulsations, which is a surrogate for the intraocular pressure at the limbus, and transmits it to this little recorder that this gentleman is holding here in his hand. And it measures the fluctuation at the level of the limbus 300 times every 30 seconds, every 5 minutes for 30 seconds, which means there are 288 readings over 24 hours for us to look at. So this is what a screen typically looks like when you have the recorder off after the patient has taken it off. And as you move your cursor everywhere, anywhere onto the screen, I hope you can see this, the fluctuations on the bottom are changing. So each of the 288 data points, you can actually look at and decide on what happened at that point in time. And coupled with the patient diary, you can actually see what happened when the patient was doing what. And obviously, as true for any recordings of intraocular pressure in a sleep laboratory, there is a sleep-wake acrophase. When the patient lies down, the pressure increases, and nighttime IOPs are invariably higher than daytime IOPs. So what is the clinical experience with the contact lens sensor? Good safety and tolerability. It's been around for more than 10 years, actually 12, because I know I was part of my PhD was on this, and that was 10 years ago. 70% of the highest signals are received during the night, and prolonged peaks are observed in many, many patients. 75% of them occur outside of our office hours. And those patients who've had the triggerfish monitoring, the therapy was changed in almost 3/4 of that patients. But of course, it's poor repeatability, exactly like a diagonal variation curve. The therapy change in 3/4 of our patients is also because it's a $1,000 device and you only use it on patients where it's actually required. So if you have somebody who's progressing, I guess you would have to change therapy. Just showing a couple of slides. I think in the interest of time, I'll not talk much about the patients, but we do know that beta blockers and alpha adrenergics do not work very well at night. And even if you did have this particular patient who was very well controlled during your office hours, you know the nighttime IOP wasn't what you would have liked it to be. Also true for prostaglandin analogs sometimes, especially in cases of pseudoexfoliation. Remember that in pseudo-X, the diurnal fluctuation is going to be much more than your regular primary open-angle glaucomas. And those of you who are listening in from the Middle East, you have a higher incidence of pseudo-X than we do. So just be very cautious of that. Otherwise, typically you would have a blunting of the nighttime peak. So it's not going to, there is always going to be an increase in your eye pressure, regardless of what prostaglandin you're on. But this just may not be as high as it would have been otherwise without the medication. Mrs. Parul and I worked on this together, so I love showing up the slide every time we are speaking together in a meeting. We've found that primary angle closure is no different from open angle glaucomas. So diurnal variation is just as important in these patients. So I'm just going to show you one little patient who's had an LBI, before an LBI, and that's what his nighttime tracing looked like. And the same patient, you would think that, that this has become better, but the diurnal curve is showing an increase just so. But if you were to compare the two, can you see that the absolute value of both the fluctuation and the peak IOP have come down? And that critically is what tells us that LPI is so critical to managing any patient of angle closure, which is why the gonioscopy, and I can't emphasize it enough because we talk about it in our country also, we are the happiest to do RNF LOCT, but we hesitate in doing gonioscopies. And this is why you must do a gonioscopy, because even the diurnal pressure curve is going to be influenced by your LPI. No medication, by the way. And this is a primary angle closure patient where pressures were not higher than normal. This is a very interesting patient, which is to highlight the fact that you can only know what the patient was doing, and you'll have these bizarre curves coming in sometimes, and you won't know what happened. So this patient at 2 a.m., there's a sharp drop in eye pressure, followed by a very high pressure. So you need to ask the patient what happened, and we usually give them a little diary where they're supposed to write down what happened. This particular gentleman was suffering from a benign prostatic hypertrophy, and he got up at 2 a.m. because he needed to use the toilet to pass urine. And this is what happened when he was urinating against a sphincter that was not really compliant. And that is so wonderful to be able to pick up. And you can actually have patients blowing into a trumpet, and you will see what happens. You will have patients doing the Valsalva. And as long as the patient has written it down, you will know what has happened, which is why the patient diary is so critical to doing it. Now, so this is what was the triggerfish contact lens sensor. So what's new that we know of? So now it also measures your eye blinks and your body position while you were sleeping. How were you sleeping, and how that influences your eye pressure. Also, this one is a prototype. It hasn't been on the market. I haven't used the absolute IOP contact lens monitor, where the newest prototype is actually capable of measuring the absolute IOP for 24 hours. The triggerfish that has been conventionally been in the market only gives you a measure of fluctuation and not the actual eye pressure. Just going to walk you through what it looks like. The microprocessor, very similar to the one in the conventional contact lens sensor, digitizes it, sends it to the antenna, but actually ends up measuring the eye pressure and recording it similar to what it would in terms of fluctuation. The body position recording is so interesting because it shows the body position based on accelerometer readings. And the sensors are placed now in that blue box that you saw the gentleman holding. That's the recorder, as well as the data cable connector. So every time you move, the contact lens sensor in the eye actually picks it up and correlates it to your eye pressure recordings. Obviously detects the eye blinks as well. So this is like an ambulatory sleep lab. You walk around with the contact lens sensor in your eye, and you go around doing your usual work. You can go for a walk, you can run, you can exercise. You can do your weight training, you can cook, you can sleep, and it's actually measuring your eye pressure while you're doing anything at all. So if you're worried if your smoking is changing things, if you're worried if you're playing the flute is changing things, you can actually get it picked up. And a greater amplitude of the cosine fit curve, and that's trigonometry, and Parul and I were just discussing how we love calculus. Actually, that and the fact that you sleep on your left lateral side during sleep is actually associated more with normal tension glaucoma. It's really interesting. It's part of the Enigma study. A small study, but very, very interesting to know that your sleep position can actually influence your glaucoma as well. So there we are. So this is what the new sensor table looks like. That's the usual tracing that we discussed earlier. But these are your eye blinks that have been recorded. And the red, green, and yellow and blue coding actually types out where you were sleeping and how you were sleeping. And this is just so interesting because if you will look, the pinks where you were sleeping on your left lateral, there was actually a slight increase, a decrease in your eye pressure. And as you turn to your right side, there's been an increase in your eye pressure. How that measures, I mean, all of us who've been pregnant, remember we were lying on the left lateral position when heavily pregnant, so we wouldn't have pressure on the aorta. Is that what we are looking at? The accelerometer-based body position indication actually gives us a wealth of data about where we are. Now, the other tool, because we're not measuring absolute IOP, that is really, really interesting for those of us who look at IOP in not just in our clinical practice, but also as a research tool, is that you can actually fit in the IOP readings taken by your tonometer, whichever tonometer, Goldman applanation, or whichever it is that you use in your practice, to understand if the patient has a potential for exceeding a defined threshold. Example, normal tension glaucoma. Since the profile information is represented as a box plot, and then you add the IOP readings at whatever times you took them, either start or end of IOP, or at similar times the day before, presuming that the eye pressure the day before is the same as the day of monitoring. Both of them are combined with a threshold value and a daily variation estimation that you choose for yourself. Like in my head, if it's more than 8 millimeters of mercury, I'm worried about that patient. The machine actually presents it to you as a box plot. So it tells you how many times the pressure went above what you thought was your threshold, and also how many times the variation was above what you thought would be normal for your patient. Again, tons of fun on the research angle. Clinical practice, this will take time in coming in. Every time I talk about the contact lens sensor, I talk of it as a researcher more than as a clinician. But what I do want you to take away as a clinician, if you're not working in pure research in a sleep lab, is that the Goldman applanation tonometry that you do is a one-time snapshot of a movie that is the patient's life. Which is why the number of times that you take IOP is so critical to making your treatment plan better. So if you take just the one IOP and diagnose glaucoma, that's not where you are. Setting the IOP baseline for treatment also has to be many, many times. And also during monitoring, if nothing else, call your patient at different times during the monitoring of the patient. Parul and I also just recently wrote an editorial about 6 months ago about the water drinking test, which is a very controversial test right now, but it's not a bad test to use as a measure of peak IOP, at least if not fluctuation. And remember that you must do your eye pressures yourself, because if you have an optometrist or an assistant doing it for you in your clinical practice, unless it's the same person every time, half the time the inter-observer agreements are going to be so tragic that you will not be able to correlate your findings. Both Parul and I are fellowship trained, and we have now enough years between us, 15 years in clinical practice, and our kappa for IOP measurements is 0.8. So 0.8, 80% of the time, Parul and I will measure the same IOP, but 20% of the time, our IOP measurements will not agree with each other. That is why it's very important to remember to do your own eye pressures in clinical practice. And as is true for all of us, we have very few data points which lead us to conclusions, whatever it is that we do in life. And if we were to use more and more data points, I'm sure our projections about what we are doing are going to be better. And I'm going to leave you with a prayer from Sir Robert Hutchison: science before art and cleverness before common sense. That will be the death of glaucoma. for all of us who practice glaucoma, I think the three things that we must remember is accept your limitations, accept the limitations of your training, find mentorship, find friends who will help you out when you don't know what to do, and try and do as much as you can yourself in the diagnostics part, and just make sure that you are doing the best you can, the best you possibly can, because science and compassion together are so critical to glaucoma management. Thank you so much for having me here. It's been an absolute pleasure.
Thank you very much, Dr. Shibel. This were an excellent and new, actually, topics that it's newly introduced. I don't know if we are using a lot here, but I don't think maybe Hayati will give us about this one, or Muhammad, but Muhammad already left. Thanks. It was an excellent presentation, but there is a lot of question actually in our minds and clarifications. So first I will give the mic for Dr. Barrel, then we will have our questions. Dr. Barrel.
Well, at least in India, Shibal is called an expert on intraocular pressure. And I agree with her that checking the pressures as many times as possible at different times of the day is very, very important for all the clinicians. This is something new for everybody. It's expensive. It's more of a research tool, as pointed out. But it's important to know the things that this new tool is bringing out. It's telling us a lot about what's happening to the eye pressure at night. So maybe if all of us cannot afford it for our patients, we can definitely take home the pearls that this tool is offering us and improvise our practice based on that. Uh, it's expensive, no doubt, but the data that it is providing is definitely adding much more to our knowledge, and the progression which is happening at the night time and how the drugs are behaving. A lot of times we are just so focused at one reading of the pressure that we ignore the peak pressure, we ignore the fluctuations that are happening, and we forget the fact that the aim of any treatment is to reduce the intraocular pressures fluctuation to less than 3 millimeters of mercury. So if your patient is well controlled on drugs and still progressing, it's a good idea to do their diurnal variation, or check their intraocular pressure at multiple times of the day to see whether it's actually dampening the fluctuation, else it's time to change the medication. I haven't used the triggerfish because I don't have a patient profile which would afford this lens, but Shibal is an expert and she has done this as a part of her PhD thesis. So I thought she was the best choice for this topic. And we all need to be enlightened about the fact that how important is IOP fluctuation. So having said that, I would like Dr. Hayat's comment on the same.
Hayat, you are mute. Can you unmute yourself? Sorry.
Thank you. Thank you, Shibal. Excellent presentation. I really enjoyed each and every bit of this talk. Very intriguing, very important aspect of glaucoma. This reminds me of my World Glaucoma Association meeting in 2015, where I happened to meet Bob Weinreb. And Bob Weinreb was talking about this hours and hours. And I actually, at one point of time, I said, well, is it really true? And yes, that is true, that he had those sleep studies and it was very thoroughly done studies. And I looked at the studies which Dr. Shibal has done. I would say yes, this is true. Unfortunately, a lot of our colleagues, especially the journal ophthalmologists, do not have an idea about the choice of medications, pressure control, the fluctuations, and the associated morbidity. Unfortunate part is that there has to be a more rigorous amount of teaching about these, especially the night elevations, and which we actually, lot of many of the meetings I just made the comment and I didn't get any response. The reason is I think there's a lack of knowing the facts, as this talk was again enumerating, and it went further into the smaller things like Valsalva and so on, which I honestly didn't knew. So it was very enlightening, and I really want to thank Shibal for this excellent presentation.
Thank you very much, Dr. Hat, for your comments. Actually, Dr. Shibal, we not just to clarify certain points, because this is a new topic, and we want to highlight about certain things that we want to learn from you. What is the maximum that you find in your research? I mean, difference between what is you are examining in the, the ordinary way, and when you are using the this one contact lens sensor. I mean, what is the difference in pressure
So the
measurement?
contact lens sensor that is available to us till now does not give us a value in eye pressure. It does not give us a millimeters of mercury value. It only gives us a tracing of how much it went down. And you have a start and stop. So you have the start and stop values. And right now, what we know is a visual representation of how much it went down. So if I can go back to a slide, I'll try and explain it to you better. Just give me a minute, please. Parul, do you think I have the liberty to do that, please?
Absolutely.
So I'm going to bring in, let's use this particular slide that we have, right? So if at the start of this, the blue curve, if the pressure that I measured was, let's say 20, and at the end, the pressure that I measured was 22, then if I eyeball this, then about 2 straight line graph points would be about 2 millimeters of mercury. So this fluctuation then will become about 1, 2, 3, 4, 5, 6, 7, 8, 9. So that will be about 9 to 10 millimeters of mercury on the blue curve from the bottom that we have seen. So that would be an approximation. It's not a number that I can give you with any level of detail.
Approximately, you are calculating. Otherwise,
that's your eye calculating. And similarly here, if this was 18 and this was 18 too, because they're both at the same level, this can only be 4 millimeters of mercury more. But that's a vague eyeballing. We're looking at fluctuation as it happens through the night. We don't have numbers to allocate for it, sadly, yet. But the prototype that I haven't had the privilege of using because I don't have access to the prototype yet. That actually gives you absolute values.
Okay, so now if we get the result, and what does it, how it affect or change your modality of treatments? So you are giving already the treatments.
Yeah. Okay. So we know that alpha adrenergics and timolol, beta blockers, do not work at night. So that's something we now know for a fact. So the first line choice drug, therefore, becomes a prostaglandin analog. And then the first add-on drug, therefore, becomes a carbonic anhydrase inhibitor. There haven't been enough studies, at least I haven't read any with the newer ROCK inhibitors that have come in. Arul, have you read something? Because I haven't. I don't think they've been explored. The other thing that I have learned in my clinical practice is to also look at your blood pressure recordings at night. So patients who continue to progress in spite of everything being normal, please ask for an ambulatory BP record because the eye pressure goes up and the blood pressure goes down. The ocular perfusion therefore becomes less, and these patients tend to progress much faster because of loss of blood supply to the optic nerve. The third thing that I am very, very conscious of now in our country, especially, there's been a revival of yoga. We've re-imported yoga into our country. So we talk of certain yoga positions which can actually aggravate your glaucoma, especially some breathing exercises where you are closing your nostril and breathing and forcefully breathing out against a semi-closed glottis. The Valsalva, for example. Patients who blow the trumpet. In fact, there's a very interesting study. I think it's from New York Eye Ear Infirmary. Right, that talks of they looked at the New York Philharmonic Orchestra and found that the trumpet players had higher eye pressures at night during when they were blowing the trumpet than other musicians, because you were again blowing against something. So these are tiny little things that can influence your understanding of the disease. And then into clinical practice, I think it brings into focus the fact that your choice of drug has to be what it has to be. One, and two, you might want to do surgery earlier in case you're not getting your diurnal fluctuation under control, because surgery is known to be the best cure for diurnal fluctuation of eye pressures. So that's one modification that will come into your clinical practice. You will also be more cognizant of your patient's lifestyle changes when you're looking at their diurnal variation. I am a firm believer, and thankfully Parul is the chairperson, so there's not going to be much argument on this, in the water drinking test. It's a very simple test to do. You don't need any fancy equipment. You can use whatever equipment you're using for your eye pressure. Make sure your patient drinks 10 ml per kg of water, per kg body weight of water, after having not had water for 2 hours. And that's when you start looking at eye pressures. Every 15 minutes, check eye pressures, see how high the pressure is going, and that gives you an index, a surrogate for what happens at 2 a.m., which is your highest eye pressure record. That's a very simple tool to estimate peak and fluctuation in a patient. Fluctuation, not so much, but peak IOPs are picked up very easily by the water drinking test. For those of us who fast during Ramadan, it's so important to tell your glaucoma patient that don't chug your water when you're breaking your fast, because I tend to do that. The first lemonade takes 30 seconds. The second glass takes another 25 seconds. Don't do that. Sip your water. I don't know how much 1 month of high pressures peaking at one particular time in the evening are going to affect their glaucoma. But these are tiny things which just might change how you look at glaucoma. And with this, every time I talk, even in India, because it's impossible for anyone to use a 1,000 euro contact lens per patient per eye, because it's not a reusable lens. It's open to research more than anything else. And this is exactly what I talk about in India also. This presentation is to tell you that there is so much about the IOP that you don't know. So when you look at your patient, let your IOP not be the only guide to what you're doing. Look at the optic nerve, look at the quality of life of the patient, look at visual field progression, and more than anything else, talk to your patient. Look at compliance. Those are the numbers that you have to look at, and not just 21 or 18 or whatever. And the WGA has been extremely cognizant of the fact that now they don't talk of target IOP as one number. They talk about it as a range of eye pressure, as well as an acceptable fluctuation that prevents damage. So that's wonderful, wonderful, wonderful for those of us who've been working in IOP.
Thank you very much. I want just maybe the last thing maybe, but in a short comment. How long you are using this, I mean, in a patient, for how long you are keeping or following, for 1 month, or you are keeping for 1 day?
24 hours. The contact lens stops recording after 24 hours, exact 24 hours to the minute.
So you are using only one time and for 24 hours?
Yes,
Okay.
and 1,000 euros.
1,000 euros.
Never forget it. It drives you mad, but it is a very interesting tool to have.
Anyway, thank you very much. That was an excellent discussion and excellent information we learned about something new. So we come now to the last and not the least, our Dr. Barol talks. It will talk about smart perimetry. Thank you, Dr. Barols, for being with us to the last minute. I know I keep you all the times like this.
Well, good evening, everybody. I will be talking about smart perimetry. The word smart I've used is because it is making use of the smarter devices that we have these days. Before we go on with the talk, some unpleasant facts before we look at the pleasant new tools at our hands. Only about 34% and 8% of open-angle glaucoma cases are diagnosed in the developing world. And more than 90% of these undetected cases have significant visual field defects that would be apparent if a standard perimetry was done for these cases. And many of our patients in the developing world, they are not able to seek good care. And even in developed world, many people are devoid of good health care because of the insurance issues. And had screening been done for these patients, a lot of during the comprehensive eye examination, a lot of patients would have been picked out. So traditional in-office glaucoma screening is not there for everybody. So we need to have something which can address this issue, even at smaller centers, even at peripheral healthcare centers. And COVID has made us realize that it is so important to have a tool which we can use to assess disease progression, especially the visual field changes remotely for our patients who are suffering from glaucoma. So despite the cases having gone down, many of the elderlies are not comfortable coming to the hospital. And this is from a virtual patient's mouth. I am a part of this glaucoma eye group, which is a patient group on the Facebook. And one of the patients just dropped in a note that, he has a visual field defect, a visual field test tomorrow, and he gets very anxious every time they take it. So the big perimetry machines a lot of times intimidate the patient, and the fatigue associated with taking the test with one eye closed in a dark room, is quite tiring for many of the elderlies. So what can be a handy solution is in the hands of many of us in the forms of an iPad or a tablet. These low-cost portable tools, they have definitely allowed us to expand our services to most of our patients, those who are not able to even reach bigger centers. And it also highlights one important thing is that with the standard achromatic perimetry, there is a lot of variation in the visual fields. And for ruling out these variation, we need to have a standard baseline of the visual fields. And for that, we required repeated testing. In a private setup, repeating testing, it costs money. So if you're using a handy tool like an iPad-based testing, then the repeat testing would cost relatively less and would still help you pick up glaucoma in one of your patients. And it can also help in improving the glaucoma screening programs in lesser resourceful settings. So let's have a look at one of the options, that is Peristat. It can be done free of cost on a 17-inch computer. You just need to have a good internet connection. It measures the visual field 20 degrees vertically and 24 degrees horizontally. It's a supra-threshold test which can give you a vague idea about the shape of the visual field effects. And then the outcome can be extrapolated on a grayscale graph, the kind we are used to seeing with the standard automated perimetry. So this Peristat has been compared with the standard Humphrey visual field perimeter that most of us use. So in the top study, the Peristat and Humphrey printouts were graded by 2 glaucoma experts and 1 general ophthalmologist, and they found the sensitivity of Peristat perimetry printouts to be about 80 to 83% and a very good specificity of about 94 to 97%. And in the bottom study, they graded Peristat and Humphrey visual field printouts by the number of abnormal points that were there on the printout. And they, again, found a reasonable sensitivity and specificity for moderate or advanced glaucoma patients, but not so much for mild glaucoma patients. So even if we are able to detect moderate or advanced patients using this tool, we would still be picking out good 70 to 80% of undiagnosed glaucoma. And that would really help salvage visual acuity for these patients. Then comes another test, which was the Visual Fields Easy test. It's available only on iPad. It has been developed by a glaucomatologist. Dr. George Kong is working in Melbourne and has developed this tool. This again is a supra-threshold tool. It measures about central 30 degrees of the visual field. The testing distance is 33 centimeters. The Goldman size 5 was the one which was used for the earlier versions of Visual Field Easy. But now with the newer version, we have the facility to change the color of the target, the size of the target, and instead of just having a white on white, we can also have a blue on yellow perimetry using Visual Fields Easy. One of the largest studies using Visual Field Easy app with just enough money to be spent on an iPad was done in Nepal, and Dr. Chris Johnson, he looked at people who were diabetics and who had glaucoma and normal people, and he found out that this tool was good for patients with moderate and advanced glaucoma, just like Peristat, but it doesn't pick up early glaucoma as well. Having said that, again, I come to the point, even if we detect these moderate or advanced glaucoma patients, we are doing a great service to many who would have gone undetected. I also use this tool in my own practice, and I have a data of about 210 eyes, and I found the same in Indian eyes also. The moderate and severe glaucoma patients, as we can see on these ROC curves, they performed way better with this tool vis-a-vis patients who had mild glaucoma. So this tool, being supra-threshold tool, can help only in patients who have significant visual field damage, which can be picked up by this device. A step over visual field easy has been developed by Dr. George Kong and Dr. Algis from Australia again, and they have worked on the limitations of the previous test, and Melbourne Rapid Fields test is something which has covered many of the folies of the previous one. There are multiple options. You have the option for a central test for moderate to advanced cases, a macular test for an end stage glaucoma, screening test for those who, for just comprehensive screening and screening OPDs, and you even have a full field test. So this is how the portal looks. Unfortunately, Melbourne Rapid Fields is a paid test, but the package which you take for the test is reasonable, so it doesn't really cost too much on the patient. I'm just trying to show you how it looks, how the target appears. This is an iPad. On that, you have the central fixation point. The fixation moves to four corners of the iPad. And because of movement of fixation, when the patient fixes the eye at the four corners, the expansive area of about 30 degrees can be checked. So this has been a very good tip which the makers have accommodated in this application, is that moving the fixation point so that a larger area can be checked. This study, which compared 6-month comparison of this portable tablet perimetry with Humphrey field analyzer, they found out that the intra-class correlation between the MRF and the CETA fast, which we do in the Humphrey visual field, for a mean deviation at 4 visits was pretty decent at 0.71 to 0.88. So they said the results were almost similar to CETA fast, and it was much faster. And we have a sort of a decent outcome which comes with this. So if you don't have a Humphrey field analyzer at a peripheral clinic, this definitely serves as a good alternative. I've recently started using Melbourne rapid field tests for those of my patients who are not able to sit for very long at the Humphrey perimetry machine. For those who have back issues, those who are not ambulatory. And this is, I've just put in one of the printout of the Humphrey visual field of the same patient, an MRF of them. So you look at the distribution of visual field effect, it's quite similar. And even the printout is pretty much similar to what you would expect from a Humphrey visual field printout. So there is no, learning curve into interpreting this tool. The outcomes look pretty similar, and this is something which you can explore. During the COVID times, Melbourne Rapid Field Group, they came out with a telehealth service wherein the doctor can share the link of the MRF to be done with the patient, which they can use on any of the tablets, and they can get a full visual field test or a macular test done. Even the near vision and the low luminance, low contrast can be done, and the data would then be emailed to the doctor who has sent the test. So telehealth is definitely an additional feature which this test offers. Now, with the previous forms of perimetry that I talked about, the patients sometimes move their head and sometimes they move their eye. And we know that to get a good output, the stimuli should be accurately localized on the retina. So the solution for this can be that you mount your tablet computer along with a clip-on eye tracker, which will keep note of the movement of the gaze of the patient. And so this is one of the eye trackers which has been used in the subsequent tool I would be talking about. It's easily available on Amazon and doesn't cost much. So eye catcher was another tool, which is a good portable perimeter. It's actually a form of oculokinetic perimetry. So the moment you move your eye when you see the stimulus, that is marked as green. And for all the areas where the stimulus was shown, but the eye could not perceive it, are marked as red. So this is a kind of a retinotopic map which the machine is forming. A step over the previous model of the iCatch was the iCatcher version 2.0, which took care of certain folies with the previous version. Now we can check 22 paracentral points using this perimetry tool. The code for this application is open access and can be accessed. It's the link is given in this paper. If somebody is interested, can use this paper and open the code and download it, and you can start using this tool. It has a good agreement with standard automated perimetry, and it is even able to separate eyes with advanced visual field loss from those which are normal. So definitely we have a lot to look forward to in terms of virtual perimetry, in terms of tablet perimetry. On the lines of optokinetic perimetry, wherein the patient is moving their eye towards the stimulus as well as towards a changing fixation point, are the virtual reality perimeters, which are making use of these virtual VR devices that are getting quite common these days. And you can access the data on even your cell phone. You can put in lenses inside the sockets which are there in these virtual perimetry devices. As you can see, there is a gamut of these virtual reality perimeters. So the moment the patient moves their eye, that is marked as a point, and this new point which the patient has perceived now becomes the fixation for the next point which is being shown to the patient. And if the next point falls on the blind spot, then they don't move their eye. So it's the eye movement which would actually happen in your day-to-day life when you see an object is what is being plotted using the virtual reality perimeters. So in a way, this is a more physiological way of checking the visual field than what we have been doing. But with passage of time, it'll become better and better. And maybe in future, we would bank more on these devices as compared to the Humphrey perimetry or the standard automated perimetry. And a lot of papers have come out during the COVID period, which have shown that, at-home virtual reality optokinetic perimetry has helped to pick up patients who are progressing, or has helped the doctors to monitor their patients and alter the therapies. So this is definitely very promising. But having said that, we have to remember that these have some limitations. They're uncomfortable for some claustrophobic patients. The sensitivity of these tests is not as good currently as the standard automated perimetry. We never know what's there for in future. The gaze tracking by the camera is not there in most models, but for that, maybe we can make use of the gaze tracking attachment that I just showed. And the normative databases for most of the populations are still very new and incomplete for many of these devices. So we will have to wait for them to be updated. Now, you would be wondering where all can you make use of these devices? They definitely serve as good tools for optometrists, for general ophthalmologists who refer the patients who are suspects in rural and remote communities, in a practice which is making use of teleglaucoma, for patients with mobility issues or who are in assisted care nursing homes, and even for home monitoring, this can be used. So I would just like to conclude by saying that a cafeteria approach is the best to provide the best possible treatment for our patients. I recommend using smart perimetry with a tinge of caution until there is sufficient evidence. But having said that, this does provide a good option to screen our patients who are not able to come to the clinic. So this is something that can be done remotely. and it definitely has a potential of teleglaucoma. Now, since we have seen COVID pandemic, we need to be prepped up for the future and develop these tools and these devices with us so that we can monitor our patients in future as well. So with that, thank you very much for having
Thank
me here.
you very much, Dr. Barrel. An excellent presentation as usual. And there is a lot of information we learn from you, and I think many questions in our mind. Dr. Hayat and Dr. Shabel, they will participate in this. So Hayat, if you have any question to Dr. Barrel.
To be honest, I've never used any of these, but they're such exciting information with these challenges that we have with the COVID pandemic. With the kind of lockdowns internationally, definitely this is one of the way to go about that we develop technologies which can be availed at home rather than, and how much sensitive and how much improvement in the especially when you talk about those virtual reality glasses, I'm pretty sure this is quite promising. I think there will be a time, I hope, that this will surpass uh, the the instrumentation that we are using at the moment. But I would definitely say that to my patients, I would like to have a try of some of these devices. I think especially I would like to know about this eye tracking device that you can you elaborate on how they can install, because that would be something challenging.
It has a USB port. So if you are using any of the tablet perimetry, so you have to mount your tablet perimeter on. There is a sort of a groove in the Tobii device that is there for monitoring. So you just have to mount your the tablet into that groove and attach the USB portal of the uh, monitoring device to the tablet, and that helps to monitor. So you get that recording if the patient is moving their head. That
Just a vague question I have, that rather than using the tablets, how about using the televisions and just mirroring the televisions to like I mean, most of us have LCDs to a certain size that can be actually incorporated. Has anybody done some work on rather than just the tablets? If we can have the televisions, because we can have a wider field and we can have a better.
there was work that was done on televisions, not really the televisions, actually the televisions used the cathode ray technology. So there was a time in late 90s when people were working to make use of that technology for the screen. But there are several issues with the luminance of the screen which did not permit the accurate assessment. Actually, cathode ray technologies were used both for contrast sensitivity testing and perimetry, so that fell out of repute. And then again, having a bulkier device is again not a portable thing. So these were options which were explored for portable perimetry, which could be easily taken to peripheral centers for screening, and that was the main purpose behind it. Because even if you are able to detect patients with moderate and advanced glaucoma from the pool of a lot of undetected glaucoma patients, you would be able to do justice to about good 70% of patients who have been undetected. So for that, these tools are really good. And I've been using MRF now for close to 8-9 months. I started using it during the COVID times. Visual field easy, I have used quite often. I used it also for my neuro-ophthalmology patients and for patients who are bedridden. So it has definitely provided a good amount of information which helps me modulate the therapy. So
So
these are
between
still
the
early times.
Yeah, between the eye catcher and the MRF, or for that matter, all of these, which would be your preferable device that you would like to ask some of your
MRF.
patients to invest in?
MRF.
MRF.
MRF, yes. So one test of MRF just costs $2. So you just need to have a basic iPad, and one test costs just $2. So it's as simple as that. Eye catcher is still under trial. Though they have an open access code for everybody, still under trial. MRF has been approved by the FDA. It has been approved by the Australian authorities and as well as Indian authorities now. So it's easily available. and it works really well.
Thank you.
Thank you very much. Is there any comment, Dr. Shibel, or questions?
Always a pleasure to listen to Parul. Always a pleasure. So what she has been emphasizing, and I will repeat it for her, is that this is a screening device. It is not a substitute for the Humphreys under situations where you can do a conventional perimetry. That's the only take-home message. Otherwise, it's a boon. During COVID, it's what sustained so many glaucoma practices. In fact, I was introduced to it by Parul, and I was a very hesitant adapter of technologies. Like, my patients are not going to do this. But it takes a little bit of cajoling, a little bit of coaxing and explaining. But it is acceptable to most patients. I'm just scared for that particular subset which will not come back for Humphreys, saying we've already done a field. But that's the only subset I'm worried about. So really, in case of advanced glaucomas that you have been monitoring and have not been able to see, in India, for example, it's been almost a year and a half of intermittent lockdowns. Those are the ones that this has actually been a boon for.
Thank you very much. I think just I have one thing in my mind just to comment about the sensitivity. What was you shown, Dr. Barol, in one, I think one of your slide, it's almost very close. One of them 83 and 84 like this. The other one is 97 in comparison to, I mean, to the Humphrey. That means it's not only a simple, I mean, achievement. It's I mean, sometimes you will not find this. I mean, even if the patient is not cooperative, you will find the same result in a Humphrey itself.
Well, it is for moderate to advanced glaucoma that the sensitivity and specificity is so good. The machine gives vocal prompts to the patient if they are losing fixation. So you have the facility here to stop the button, just press one tab on the iPad and you can just stop it, the test, and redo the test. So that is something which you don't have in Humphreys. So for many of our patients who were having unreliable tests, repeatedly tests having low test reliability, the MRF has served as a good tool. And I work in a government setup in India where there is not too much of funding, and my patients are not too fancy to afford anything. Even those patients have done a good test with this, and I have been able to sort of get some sort of an idea to modulate my therapy for these patients. So out of whatever I've talked about, I've used Visual Field Easy. The data interpretation with VFE is a little difficult because there is a sort of a code which you need to use to translate the data into a printout. So that's a little time consuming, but MRF is from the same people, the same group, and they have taken care of all the folies of the previous system and really works well for patients. We are not doing it in our day-to-day practice. We are using it for times when HVF is not possible. But having said that, we are going in the direction where we can develop a tool which can come in handy when needed. So for that, we need to keep trying, and we will stumble and will definitely come to a point where we can develop a system wherein even sitting remotely, you can do all the tests and you can get an idea how your patient is faring.
Before we continue to our last question in my mind, if there is any other question from for all participants, the link for having a certificate of attendance now in the chat. So please, if you want to download your certificate of attendance. There is one thing in my mind, Dr. Barol, sometimes maybe you can get benefit from this one for follow-up even the patient. Sometimes you do a Humphrey and you know about your patient, then you teach your patient how to use, and then he can go home and you can follow up. Is there, I mean, something that's in a benefit like this?
So if you have one patient who comes to you now, but is not able to come to you for another 6 months, in between, you don't want to lose insight into what is happening to that patient. So these can be used for inter-visit data. You can have some sort of an idea after using this test that how he fared in these 6 months. And when they send you the data in between, and if you see visually that the test output is deteriorating or it is worse than the Humphrey perimetry, then you can always call the patient in between also. So now the patient also has a concrete thing to see that, it's time to go to the doctor. So many a times, many elderly individuals who are 80 plus are reluctant because they feel that, even if we come, you're going to give us the same medications. So they tend to lose the reason to come to you. So if the test picks up any change, they have a reason for compliance and for having, for following up back with the physician. This is definitely not a replacement for what we are standard automated perimetry, but a good adjunct in times when the patients are not able to follow up.
Thank you very much. It was a very interesting sessions, discussions. We learned a lot from all of you. Thank you very much. Thank you, Dr. Shibel, Dr. Barrel, Dr. Muhammad, and Dr. Hayat. And thanks for our participants. They joined us to the last minute. I was thinking to make only 1 hour. You see, now we crossed 2 hours. But I think because of the nice discussions, new topics, and very nice and healthy and new information, we hope that we deliver a lot of message to our colleagues, and we are ready, I think, also to send us any questions that we can also send to our colleagues, and they are, I think, ready to answer any question in your mind. Thank you for all, and thanks for our management event for supporting this event, and have a nice day. And before we leave, just I want to remind all the colleagues here that we are having a conference, MEOM conference on 23rd to 25. And already the link is sent to everyone through the email and through the Facebook, through the WhatsApp. So you can register. It's a free registration with CME accreditation. We are having a lot of speakers internationally, and we are having more than 24 sessions. We are having more than 165 international speakers. They are going to deliver all subspecialty and cover all subspecialty in ophthalmology. Thank you for all. Thank you, Dr. Shibel. Thanks for being with us. I'm happy that you are with us. Dr. Barrel, I don't know how to thank you. You are all the times the stone for doing all the glaucoma session. Dr. Hayat, my dear friends, and also my regard to Dr. Soheb. Thank you for all, and good night.
Good night.
Bye-bye.
Good night. Bye-bye.
Thank you.
Thank you.